everyone.
Okay.
We've been gone for a while, so welcome back to the Gyno Gurus podcast. So we're actually going to be starting a series over PCOS. So this is a topic that both Dr. Mandel and I really enjoy, just because it ties very closely to metabolic dysfunction. So actually we initially had recorded an episode of this, but it was just very long because there's so much to discuss regarding this syndrome. So we decided to actually start over and kind of break it up into some pieces because we thought it would be a little bit easier to just
Definitely
digest.
easier to swallow.
Yeah, to digest and then, take it in pieces, and then we can put the whole picture together at the end of the series. So basically, we'll just kind of start with talking about what it is. We're going to go over diagnostic criteria today. We're going to go over symptoms that patients experience whenever they have PCOS. We're going to briefly talk about pathophysiology just on a very high basic level. And then we're actually just going to end with the typical workup that we'll do for PCOS when patients come presenting with the symptoms that we're going to be talking about today. So just to start, so PCOS stands for Polycystic Ovarian Syndrome. And this is one of the most common endocrine, metabolic, hormonal dysfunctions in women. And unfortunately, I would argue that in a lot of cases, this syndrome is, I would say, undertreated, especially from a metabolic standpoint. But yeah, so I'll have Dr. Mandel just kind of tell us about the diagnostic criteria for PCOS. And then I also just want you to kind of touch on the difference between like a disease versus a syndrome, because this is a syndrome.
I think that's very a good thing. Mm-hmm. So a syndrome is sort of like a constellation of symptoms that can be attributed to maybe a number of different pathways to get there. A common example is like irritable bowel syndrome. It's a syndrome. People could have, its effects on the bowels, but there's not one specific cause of it. And you can look at polycystic ovarian syndrome, and so it's a constellation of symptoms. It's not a specific disease, in the sense that, for example, say being like you can have a metabolic syndrome where you're overweight and have high blood pressure, and that could definitely be part of polycystic ovarian syndrome, but it could also be part of Cushing's syndrome, which is too much cortisol. So there's, you can have different things give you the same look clinically, but like when we evaluate somebody for polycystic ovarian syndrome, we want to rule out those kind of things. So thyroid can overlap. You can have even like somebody can have high androgen levels in polycystic ovarian syndrome, but maybe they'll have high androgen levels because of side effect from a medication. There could be some anti-seizure medicines can do things like that. You can have irregular periods, which is very common in polycystic ovarian syndrome. As a matter of fact, it's part of the diagnostic criteria of it, but other things can cause, irregular periods. So you can have somebody who's, say, overweight, which is very common, who has thyroid dysfunction, and they don't get their period regularly. Well, that's the cause, likely, rather than polycystic ovarian syndrome. Mm-hmm. So when we do an evaluation for polycystic ovarian syndrome, what happens is the patient comes in with a group of symptoms, and then we say, well, this is the most common cause of it, so it makes us think, well, let's evaluate you for that. But while we're doing that, we also have to rule out thyroid dysfunction, high
prolactin levels, Cushing's, and congenital adrenal hyperplasia.
Yes.
But I think too, like even talking about just like the syndrome as a whole, it's like, can you just talk about like what that diagnostic criteria is?
Absolutely. So the diagnostic criteria is really the most common thing. The criteria that's used is called the Rotterdam criteria, which is basically irregular periods or no periods. High signs of high androgen levels or laboratory measurements of high androgen levels. So androgens cause things like acne, abnormal hair growth like facial hair in women, or hair on the chest, particularly between the breasts and between like the belly button and the pubic hair triangle. And then on ultrasound, you'll see multiple small cysts in the ovaries, which are really eggs that just are immature eggs that aren't developing.
Little antral follicles.
Yeah, exactly. And the ultrasound criteria, it depends who you look at, but typically if you have 12 of those in one ovary, that sort of meets the criteria for, I think most people would say that.
Sure. Yeah.
So,
And I think too, it also depends on your ultrasound tech. I would say like, and we'll have like a little diagram of what we mean whenever we're talking about these cysts on the ovary, just because I honestly feel like it can kind of be confusing for some patients, because it's normal and actually healthy to have follicles. But like what we're talking about is a very distinct look of the follicles on the ovary. So in like a healthy ovary on an ultrasound, the best way I can describe it is I feel like it kind of looks like a chocolate chip cookie. Like it's you just kind of have like the random little antral follicles. They're all happy in the middle of the ovary. And then for whatever reason in PCOS, they really only sit on the periphery of the ovary. So we actually call that a string of pearls presentation. So it's just kind of interesting.
Yes. And, one thing that follicles and cysts, what's the difference? So a cyst is just a fluid-filled sac, and eggs develop in small cysts, but we call them follicles. And like when we're looking from a fertility point of view, to see if a woman's going to ovulate on ultrasound, we can actually follow a small follicle early in the cycle, get bigger and bigger, and eventually gets to the point where ovulation occurs. So follicles or these small cysts can be healthy, but it's in context to how they are.
Sure. Yeah, definitely.
Yeah.
And then just to kind of wrap up with the, I guess, diagnostic criteria of this syndrome, since we have 3 of those criteria, we really only have to meet 2 of the criteria to be diagnosed. But that being said, since we do have the 3 main criteria, you can have different what we call phenotypes of PCOS. So you can have many different presentations of PCOS. So there are some people who have PCOS that do not have polycystic ovaries on an ultrasound. And I think some people are, I have to have polycystic. No, you do not have to have polycystic ovaries if you have irregular periods and acne. Even if your blood work is normal, you still meet the criteria for the diagnosis of polycystic ovarian syndrome. And the reason why it's important to be able to kind of differentiate some of the phenotypes is because the treatment depends on your phenotype. Not all treatments for PCOS are exactly the same. And that's why it's important to, have a clinician who really looks into those things and knows what they're talking about whenever it comes to PCOS. So, and then kind of just moving on to some of the symptoms that patients experience. I think high level, you covered a lot of it. Irregular periods, or we call it oligomenorrhea or amenorrhea, which either means very irregular, your period hardly comes.
Right. I think the criteria is 9 or fewer periods in a year.
Mm-hmm. Yeah.
Is a technical
term, or no periods at all. Definitely have had patients who have not had a period for a couple of years, which is scary because you need to be having your periods for endometrial protection, which we'll get to that in a later episode. Other things like he talked about acne, central hair growth, even weight gain. There, is some evidence of like mood disorders, which honestly is not really discussed a whole lot in women with PCOS. So we'll get into that also in a later episode as well. That's beyond the scope of kind of what we wanted to talk about today. And then also, of course, untreated PCOS, if you're not ovulating healthy and regularly, infertility is definitely, a side effect of having untreated PCO. So do you have anything to add to any of those? Or?
Well, I guess there's also potentially associations of like sleep apnea due to overweight.
Yeah.
And but then on the laboratory testing, that's really something we should talk about.
Definitely.
Because it has significant metabolic issues. So it's not only reproductive issues, which are very important, but even after somebody's done with her childbearing, the metabolic ramifications are extraordinarily important to your long-term health and well-being.
Definitely. Which, if you go back to our insulin resistance episode, which is where most of that will stem from, metabolically speaking, in women that have PCOS, a risk of hypertension, cardiovascular disease, type 2 diabetes, all the things. But I did want to back up to just the fatigue. So Dr. Mandel had sent me a study the other day. Remember, of the vitamin D and PCOS?
Oh, yes.
Another reason for potential fatigue, along with chronic inflammation associated with PCOS. Women with PCOS are much more likely to have low levels of vitamin D. And I'm not really sure why. I saw the study that you sent me. I'm not going to lie, I did not read it. So if you would like to elaborate on that a little bit more, I think that would be interesting.
Well, I don't think they really specifically explain why, but there's an association between low levels of vitamin D and PCOS. And low levels of vitamin D can cause all sorts of metabolic issues, even heart disease, which is, one of the things that we worry about. And I think when I was talking to Alex about that study, I was saying maybe we should include vitamin D levels as part of our workup, because it's associated with this metabolic dysfunction. And so chronic vitamin D deficiencies can lead to all sorts of things, even muscle weakness. When you're younger, in particular, your bone density, your maximum bone density you build when you're younger. So by the time you hit your mid-30s, you're probably peaking on your bone density. And if you have chronically low levels of vitamin D, it might interfere with that. And that is another metabolic issue, which I haven't really seen talked about in this arena. But it's very important for long-term health, is keeping your skeleton strong, so that later on in life you don't become that old hunched over person.
Mm-hmm. Yeah, you don't want to become fragile. So all very interesting things. But the vitamin D, I think I actually do order vitamin D on every, but it's mostly because they always tell me that they're tired. So, but that makes sense why. Yeah. So, anyways, and we're just gonna do quickly just a basic overview of just the pathophysiology of PCOS. Do you want to discuss that, Dr. Mandel?
Oh yeah. So PCOS is the end result is that you don't ovulate regularly. The factors that cause it and raise androgen levels, so the higher androgen levels are caused by a multitude of things, but in particular on the cells around that follicle, theca cells, they produce more androgens, and that's related to higher insulin levels, because many cases of PCOS are related to insulin resistance. And insulin resistance means that in order to control your blood sugar, your body makes higher and higher levels of insulin, and that drives or prevents the metabolism of androgens into estrogens in your ovary. And then additionally, you have higher levels of gonadotropin, which stimulates the ovary to produce eggs and to ovulate. So in PCOS, you don't get so much of a cyclic change. So in the beginning of a menstrual cycle, you get a signal from the pituitary gland to the ovary, FSH, or follicle stimulating hormone, to produce eggs. And then as those eggs are being produced, estrogen levels rise, stimulates the release of a second gonadotropin, luteinizing hormone, or LH, which triggers ovulation. Well, if you have chronically elevated gonadotropins, which is what happens in PCOS, the chronic LH stimulation also causes the production of androgens.
Yeah, so it stimulates the theca cells to convert more cholesterol to testosterone,
Yeah.
and then it can also decrease the amount of that's aromatized to estrogen, like you were saying. And the way that actually happens is really interesting. But again, we're gonna make y'all wait for that and wait for another episode. So, but yeah, and then the last thing too is that it actually does insulin resistance, chronic insulin resistance does decrease sex hormone binding globulin, which makes you have more free androgens, testosterone.
And the biologically active form of the testosterone is the free form. So you can have you have proteins in your blood that bind some of the testosterone, and the more of those proteins you have, the more is bound, which means that for whatever level of testosterone you have less free testosterone. The free is the biologically active form that causes things like acne and hair loss and abnormal hair growth. So you want to keep your free testosterone lower. If you have less sex hormone binding globulin, you have more free testosterone, which causes more of those issues.
Yes. Yeah, so that's just kind of like a high-level basic overview. I mean, we could literally probably spend an hour talking about the pathophysiology and depth of PCOS, but I think this is like a good start, and I think we'll probably get more into the details maybe in later in the series. So I just wanted to kind of finish up by talking about, like, if someone comes into the office and has, all these symptoms, it's like, well, what do we do for them? Like, how do we start? And it's basically you're starting with ultrasound and lab work. And so I just kind of wanted to talk about the labs that we do. Obviously, we talked about, with polycystic ovaries on ultrasound, like how we're basically looking like, do we see a string of pearls here, or does this look normal? But then in terms of lab values, basically, it's like, what are we doing and why?
Okay, so we want to check for androgens. So there are different androgens that are typically checked. That would be testosterone, DHEAS, and androstenedione, which are all produced by the ovary. And elevated levels, particularly of testosterone, probably more than any other, is part of the diagnostic criteria. And the other thing you want to get is ultrasound, because that's also part of the diagnostic criteria. So you have two, we'll say, studies, ultrasound and lab, that are part of the criteria to make the diagnosis of polycystic ovarian syndrome, and plus history of irregular periods. And then basically we want to check the gonadotropins. Like we said, chronically elevated gonadotropins, particularly LH, is associated with polycystic ovarian syndrome. You could get also AMH, anti-Müllerian hormone, is elevated in that.
Which is not a marker, but if it's high, it's indicative of having increased ovarian volume, which is common with PCOS.
More follicular
follicles
around. So, and then then there are ancillary things to look for related to metabolic dysfunction, insulin levels, glucose levels, checking a metabolic profile, particularly looking for liver function tests, because fatty liver is also highly associated with this, especially when insulin resistance is involved. A hemoglobin A1C, you'd want to get like uric acid, for example, can be elevated in metabolic syndromes. Lipid panel. You could even drill down deeper into just, rather than a straight cholesterol profile, but that's sort of like a whole separate discussion is dyslipidemia. But one of the things with PCOS that we see is relatively high triglycerides, and some people consider a triglyceride to HDL ratio is an important criteria of especially the dyslipidemia associated with PCOS. So if your triglycerides are more than twice your HDL, certainly more than 3 times, that's a significant sign of that. And then you have to rule out the other things like we were alluding to earlier in the podcast, like thyroid dysfunction, high prolactin level. Prolactin is a hormone produced in the pituitary gland that can cause irregular periods. You have to rule out Cushing's disease, something called congenital adrenal hyperplasia, which is like it's a enzyme deficiency that prevents the conversion of 17-hydroxyprogesterone into adrenal hormones, so you get a rise in your 17-hydroxyprogesterone. So that's how you basically evaluate for congenital adrenal hyperplasia. So most clinicians, I think, probably do 17-hydroxyprogesterones.
Yeah, and their
for that
PCOS
reason.
workup. Yeah, definitely.
So,
but yeah, I think overall, I mean, I think this was a good intro, just kind of like high level getting into PCOS. I always think that the whole like syndrome aspect of things is always interesting because I feel like you'd always be like, yeah, it's like you don't really know what is. There's a whole bunch of things that you just kind of throw into a bucket and you're like, this fits under this umbrella, so that's what we're going to call it.
Yeah.
But I think, the important thing is like even with the lab values, you're not always going to have abnormal labs. You're not always going to have an abnormal ultrasound. It's like sometimes this diagnosis is based on just history and that's it. And so I think that that's a good start. I don't really have anything to add. I think that, next time we'll probably get deeper into the pathophysiology, kind of talk about what comes first, insulin resistance, or does something else come first? Where does PCOS actually start? Is it possible that you got it from your mother?
Well,
so I think that we have some fun content coming up, and I'm excited about it. But yeah, so if you enjoyed this video, please like and subscribe, and then we'll be back next week.
We look forward to visiting with you again soon.